every cancer is treated slightly differently. Stereotactic radiation is, in simple terms, delivering high doses of precision radiation in a short number of visits, so up to 5 visits or so. I suppose in order for one to be eligible for targeted or stereotactic radiation, one needs a cancer that's localized to one particular region. So where it's in a certain location, it's a certain size, whereby targeted radiation can all be delivered safely. Stereotactic radiation really is just more convenient for patients, more targeted, more focused, and at the same time has the benefit of minimizing dose of radiation to surrounding tissues. From a patient perspective, I think the important thing would be to ask your radiation oncologist or your doctor, is stereotactic radiation an option for you? And then they may tell you, look, it isn't, and explain that to you. Broadly speaking, there are 2 main criteria on how one would decide if they would use stereotactic radiation. And they're tumor factors, so depending on the tumor size, its location, where it is, whether it's spread or not, and then patient factors. This is a treatment that happens as an outpatient. It is highly pinpoint, highly precise, but I suppose the downside to that is patients need to be on a machine for a more protracted period, so typically the order of 30-40 minutes. So if a patient was in pain and wasn't able to lie flat or wasn't able to hold one's breath, then targeted radiation may not be feasible. Another complementary use of it is some of those patients, surgery might be considered as an option, but surgery might not be something that would be in the patient's interest. So stereotactic radiation can definitely complement and lead to good outcomes for patients where surgery may not be the right option for them, depending on where they're at in their journey. The initial use of stereotactic radiation was in the treatment of brain tumors. So in the brain, it worked quite well because it's easy to keep the brain still or keep the patient's head still. Then it's moved outside of the brain to treatment of early lung cancer. More recently, it started to be used in the treatment of spinal tumors with better pain outcomes, better eradication of disease in the spine. And again, more recently, it started to be used in liver tumors, be that in primary liver tumors that have originated in the liver or secondary liver tumors that have spread from elsewhere. And the outcomes in all of those seem to be comparable to surgery, but without the need to undergo a massive operation. The other tumour in which it's more commonplace now is in the treatment of prostate cancer, whereby historically men could be treated over 4 or even up to 8 weeks. Now men can be treated in 5 days. In cancer, treatments are constantly improving. In the same way, our surgical colleagues have the robot and their outcomes are improving from an operation perspective because it's more targeted and more focused and minimizing dose to important, or minimizing the radiation to important organs. The outcomes are improved, but the side effects are less.